Welcome to Derm Drop. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other sources in the dermatology community. Episode 19 includes 4 segments, starting with the role of IL-1 in hidradenitis suppurativa. Will lutikizumab be a game changer? Followed by efficacy and tolerability rankings of atopic dermatitis topicals. Then, when to worry about vasculitis. And finally, oral tranexamic acid plus exogenous estrogen. Is it safe? It's fun stuff as always, so let's get started. Question: what do knee arthritis and hidradenitis suppurativa have in common? Answer: high levels of interleukin 1. But AbbVie's IL-1 alpha/beta inhibitor lutikizumab didn't perform well in their knee arthritis trials because osteoarthritis is often more biomechanical degradation than cytokine driven. Surprise! So AbbVie trialed it in ulcerative colitis, which also demonstrates upregulated IL-1 signaling. But it turns out IL-1 is a redundant upstream pathway in UC, and blocking it alone was not enough. So that program ended this year. Meanwhile, the development of Johnson & Johnson's IL-1 alpha inhibitor bermekimab for HS was also terminated this year after phase 2 trial data published in August failed to show clinical efficacy. So is IL-1 inhibition dead? Not by a long shot. In fact, lutikizumab may be poised to be the next big player in HS as its phase 2 data clocked the highest week 16 placebo-adjusted HiSCR 50 delta we've seen yet, as the response rate for those on drug was 24 percentage points higher than those on placebo, versus bimekizumab's 20% difference. And that was in a more refractory patient population comprised of all TNF failures with mostly Hurley 3 HS. So why did bermekimab choke when lutikizumab is crushing it? Because bermekimab only inhibited IL-1 alpha while lutikizumab blocks IL-1 beta 2. According to a commentary on the role of IL-1 in HS published October 31st, 2025 in the Journal of Investigative Dermatology, IL-1 alpha is 6 times higher in HS lesions compared to healthy skin, while IL-1 beta is 130 times higher. So the beta isoform is the key IL-1 driver in HS flares. Avalo Therapeutics is betting on the beta 2, as they just finished enrolling HS patients in phase 2 trials for their IL-1 beta inhibitor. Don't hold your breath though, IL-1s are still a couple years away from FDA approval. But while they're working their way through the pipeline, JAK inhibitors like Incyte's povorcitinib will soon hit the HS market. Povorcitinib's phase 2 active/placebo HiSCR 50 delta was plus 15 to 19% at week 16, but in phase 3, the primary endpoint was extended to 24 weeks, at which point the delta reached plus 22 to 26%. Perhaps equally important as HiSCR rates is the widening range of MOAs as we learn more about the various HS phenotypes and their different cytokine signatures, clinical presentations, and treatment responses. Endotype biomarkers are being studied, but while clinical assays are not currently available, HCPs can correlate the history and exam with the underlying immunopathology to make targeted treatment recommendations. Here are some evidence-based phenotype/therapeutic pairings. For painful nodular flares, for example, an IL-1 or JAK inhibitor may be best. For chronic smoldering inflammation, pick a TNF inhibitor. For draining tunnels, go with an IL-17. For fibrotic scarring, they're going to need deroofing or laser. And for recalcitrant patients, mix and match. For example, an IL-17 plus JAK inhibitor either daily or as needed. HS sucks, but not as much as it used to. Increasing understanding of its phenotypes coupled with new weapons in the armamentarium will enable us to meet the rising incidence rates head on. Dermatology clinicians have so many topical anti-inflammatories for atopic dermatitis now. How do you choose? To help you navigate the new topical landscape in AD, researchers at the Johns Hopkins University School of Medicine and the University of Arizona College of Medicine summarized the findings of a 2024 Cochrane Systematic Review and Network Meta-Analysis of 291 randomized controlled trials, including nearly 49,000 adult and pediatric patients, in a clinical evidence synopsis published October 29, 2025 in JAMA Dermatology. And DermDrop brings you the highlights. First, the most efficacious in terms of IGA 0 or 1 odds ratios compared to vehicle. Topping the list, ruxolitinib, followed by very potent topical corticosteroids, then tacrolimus 0.1%, moderate topical corticosteroids, tapinarof 1%, roflumilast 0.15%, pimecrolimus 1%, crisaborole 2%, and finally mild topical corticosteroids. Interestingly, delgocitinib 0.5% ointment, approved in Japan for AD, weighed in at an impressive 10.06 odds ratio compared to ruxolitinib's 9.34 odds ratio. In the US, delgocitinib 2% cream was FDA approved for chronic hand eczema under the brand name Anzupco after the Cochrane review was published. But as a pan-JAK inhibitor, inferences can be made. The review also ranked the topical's tolerability in terms of the odds ratio of local adverse events compared to vehicle. Roflumilast came in at the most tolerable, followed by very potent topical corticosteroids, moderate topical corticosteroids, mild topical corticosteroids, tapinarof 1%, pimecrolimus 1%, tacrolimus 0.1%, and crisaborole 2% as the least tolerable. Ruxolitinib's local adverse event odds ratio was, quote, not estimable, close quote. Keep in mind that topical corticosteroid formulations vary widely in their concentration of emulsifiers, surfactants, solvents, and penetration enhancers such as propylene glycol, which do turbocharge drug delivery but can damage the skin barrier and have a significant impact on tolerability. The primary weakness in these findings, though, is that most of them were deemed by the authors to be of low to moderate certainty. Also, the median duration of treatment was 3 weeks, so therapies that are slower but may catch up later might not be accurately represented in this analysis. Unfortunately, longer-term data are limited for some of these agents. And 89% of the RCTs included had a high risk of bias, perhaps due to industry funding, as that was the predominant source. Given these relative shortcomings, do the results align with your clinical experience? Patients often get very concerned about the sudden appearance of vasculitis, especially when it's extensive. But when should you worry? Up to 90% of small vessel vasculitis cases are skin limited, secondary to a transient trigger, and resolve in 2 to 8 weeks without sequelae. So we provide comforting reassurance despite that nagging thought in the back of your mind that it could be a manifestation of serious underlying disease or potentially life or organ-threatening systemic vasculitis. Small vessel vasculitis, which includes leukocytoclastic vasculitis, IgA vasculitis, aka Henoch-Schürlein vasculitis, ANCA-associated vasculitides, or cryoglobulonemic vasculitis, etc., is most commonly idiopathic, but can be caused by infection such as staph, strep, hepatitis B or C, HIV, etc., drugs such as antibiotics, NSAIDs, thiazides, anticonvulsants, and allopurinol, autoimmune disease such as SLE, RA, Sjogren's syndrome, and IBD, and malignancy. Thankfully, less than 5% are due to malignancy, usually lymphoma and leukemia, but sometimes it's lung or colon. And that's a big workup, so you scan their medication list to ensure they haven't started one of the common offenders in the last few weeks, treat symptomatically, and nibble your nails while you watch and wait. But when do you bite the bullet instead of your nails and do the workup? There hasn't been an evidence-based protocol to guide that decision, so the authors of a case control study published online October 22, 2025 in JAMA Dermatology compared 87 patients with systemic disease to 343 skin-limited controls to identify factors associated with systemic involvement to improve risk stratification and prognostication. Their multivariate analysis found that the following factors were significantly associated with systemic disease: nausea and vomiting, ulcerating or necrotic skin lesions, abdominal pain and cramping, fatigue, malaise, and lethargy, or hematuria. A univariate analysis also identified joint pain and younger age. But even if these are more modest predictors, they warrant inclusion in your bedside risk calculation. If your patient has one or more of these, or their vasculitis is persistent or recurring, do the workup. So what's the workup? A basic workup includes CBC, CMP, ESR/CRP, UA, and a fecal occult if the patient has GI symptoms. Broader workup should be based on history and clinical suspicion. For example, for suspected infectious cases, hepatitis B or C, HIV, etc. should be tested. Rheumi patients with personal or family autoimmune history should have an ANA, RF, ANCA, anti-Ro, anti-LA, complement cryoglobulins, etc. If malignancy is suspected, get a chest x-ray and an LDH. And if monoclonal gammopathies are on your differential, an SPEP, etc. would be warranted. You may punt some of this to the appropriate specialty, but if you screen patients at the first visit, you can avoid diagnostic delays and further systemic complications by ensuring timely referral. Thanks to the authors for giving dermatology clinicians decision data for a common but potentially serious complaint. Derm dilemma. Your patient has mixed dermal and epidermal melasma inadequately controlled by triple combination cream, so you reach for oral tranexamic acid, but the patient is on a combined hormonal contraceptive or hormone replacement therapy. Go or no go? Tranexamic acid is the best studied pharmacologic agent that addresses both the dermal and epidermal components of melasma, which it does by blocking plasmin, reducing melanocyte activation, vascular proliferation, and inflammation. And it reduces relapse rates. But tranexamic acid also reduces fibrinolysis, which is how it stops uterine bleeding, while estrogen increases fibrinogen, as well as clotting factors 2, 7, 8, and 10, and decreases antithrombin 3, which is why it increases the risk of VTE in women on combined hormonal contraceptives. But the absolute risk is still quite low at 10 events per 10,000 woman years. A 2021 study found a similar dynamic with tranexamic acid, a low absolute VTE risk despite an increased relative risk, with the number needed to harm approaching 79,000 per 5-day course, which are not bad odds. Even more reassuring, a 2019 systematic review of 22 RCTs found no increased risk of venous or arterial thrombosis in non-surgical patients on tranexamic acid, and no significant increase in thrombotic events in surgical patients. But what about combining tranexamic acid with exogenous estrogen? Is there an additive risk? The tranexamic acid label was updated in 2013 to include concurrent combined hormonal contraceptive use as a contraindication following post-marketing thrombotic events, but a November 2025 scoping review asserted that the labeling is based on limited and low-quality evidence. Unfortunately, there's still no robust data on tranexamic acid plus combined hormonal contraceptives, and even less on tranexamic acid plus hormone replacement therapy. But that 2025 review found no thrombotic risk increase in patients with high physiologic estrogen on intermittent tranexamic acid. And a 2017 trial found no increased risk of VTE in postpartum women on tranexamic acid, and they have hormonal balances similar to those on combined hormonal contraceptives. Perhaps the authors of a 2021 survey summarized the current state of affairs best when they wrote that the concomitant use of tranexamic acid with combined hormonal contraceptives is, quote, prevalent and relatively safe, close quote, while noting that further research is warranted. Until that research is done, what do? Well, you do a good old-fashioned risk-benefit assessment, patient education, and shared decision-making. Here are some risk categories to guide you. Under no additional risk is non-oral estrogen, i.e. transdermal or vaginal. Under low risk is smoking, believe it or not. Under increased risk are obesity and age greater than 45 years. And in the highest risk category are immobility, malignancy, and history of VTE. So if your patient seems like a good candidate, counsel her regarding VTE warning signs such as leg swelling and pain, dyspnea, and chest pain, document the discussion, write the prescription, and see the patient back in 3 months. Tranexamic acid efficacy plateaus in 3 to 6 months, giving you an opportunity to reassess and limit unnecessary exposure. Then continue tinted SPF daily and hydroquinone as needed until their next post-summer pulse. And that wraps up episode 19. Derm Drop is written and hosted by me, David Sider, with distribution and administrative support by Jacob Gary. Full text and links to the articles discussed in this episode can be found at linkedin.com/in/Dave-Seiter, spelled SEITER. Questions and comments can be sent to us at dermdrop@gmail.com. If you had a good time and learned something useful, give us some love with a thumbs up, 5 stars, comment, or review, and be sure to tell your colleagues. Thanks for listening, and tune in again in 2 weeks for more dermatology quick picks in the next episode of Derm Drop.